Hi, my name is Nancy, and this is my YouTube channel on CRPS, also known as Complex Regional Pain Syndrome, RSD, and Reflex Sympathetic Dystrophy. In this channel, we will take a deep dive into CRPS, talking about what it is, how it's treated, and associated illnesses. So stay tuned for more. Today we're going to talk about medications that are administered by mouth. Oral medications are often prescribed, especially in the early part of CRPS. Here are some of them that may be prescribed, but there could be others as well. Gabapentin, also known as Neurontin, Lyrica, also known as pregabalin, Cymbalta, ketamine troches or time-release capsules, medical marijuana, either a tincture in oil or smoked, steroids, narcotics, LDN, which is low-dose naltrexone, and dexamethorphan. Gabapentin falls under the category of an anti-convulsion medication or an anti-seizure medication. It is used to treat nerve pain as well. It is estimated that 30 to 40% of those who are prescribed gabapentin find that it gives them pain relief. It was first approved in 1993 and became generic in 2004. It's often the first drug prescribed for someone with CRPS. Studies have shown that if gabapentin is more effective when it's coupled with the antidepressant amitriptyline, also known as Elavil, or an opiate. These combinations push the effectiveness up to 50%. Gabapentin should not be prescribed to someone with known kidney disease, and it should not be prescribed to someone who is pregnant or breastfeeding because the effect on the baby is not known. Side effects of gabapentin include dizziness, somnolence, fatigue, peripheral edema, which is swelling of the extremities, arms and legs, memory difficulties, respiratory depression, and tooth decay. For me, I didn't get any significant amount of pain relief. I had a very dry mouth, which contributes to tooth decay, and I could not think clearly. For me, the side effects outweighed any benefit. But until you try the medication prescribed by your physician, you will not know what your risk to benefit ratio will be. Lyrica. Lyrica is also an anticonvulsant or seizure medication. It is also commonly used to treat nerve pain. It can cause a severe allergic reaction. Some people have suicidal ideation. It should be used cautiously in diabetics or people with heart disease. Lyrica should not be stopped suddenly, as it can cause severe withdrawal symptoms. And Lyrica is not approved to use in anyone 18 or younger. Lyrica works on the central nervous system. Some of the side effects of Lyrica are dizziness, sleepiness, headache, fluid retention, nausea, blurred vision, dried mouth, weight gain, and difficulty concentrating. They continue on with breathing problems, a racing heart, swollen lymph nodes, trouble swallowing or throat tightness, itching, nausea or vomiting, dizziness, and angioedema, which is swelling under your skin in multiple parts of your body. and suicidal ideation. As for any treatment, you will need to evaluate your own risk versus benefits. For me, I could barely keep my eyes open. I was sleeping way too much and I really didn't get much pain relief. So for me, the side effect of sleepiness outweighed any potential benefit. Until it is prescribed to you, you cannot make an evaluation. Cymbalta, also known as duoxetine. Cymbalta is an antidepressant. It is classified as a serotonin neuroepinephrine reuptake inhibitor, also known as SNRI. It is used to treat depression that accompanies CRPS. It is also used to help with nerve pain. It is given to people with arthritis, diabetes, chronic back pain, fibromyalgia, and CRPS. Side effects of Cymbalta may include, but not be limited to, nausea, dry mouth, constipation, drowsiness, increased sweating, increased blood pressure, a lack of interest in sexual relations, vision changes, and in a small number of people, especially those under 25, may experience suicidal thoughts or attempts. Cymbalta was a medication I was on for a long time in combination with another antidepressant. Once I began getting regular IV ketamine infusions, my psychiatrist felt I could wean off both antidepressants one at a time. Never stop this medication cold turkey. Ketamine troches. This is a lozenge that you dissolve under your tongue, which is sublingual, or between the cheek and your gums, which is buccal. They can be used between IV infusions for both depression and CRPS pain. They are not prescribed to replace IV ketamine for the CRPS pain patient. It is a Schedule III medication. Extended release ketamine capsules, just like the troche, it cannot replace IV ketamine for CRPS pain. It is used at home to enhance the effectiveness of IV ketamine. It helps ketamine stay in your system. Orally, as in with the capsule, only 20% of that medication is absorbed. Side effects of ketamine, extended release capsules, and troches are an increase in blood pressure, risk of interstitial bladder disease, which we will again talk about when we talk about complications, memory deficit, nausea, somnolence, stimulates the cardiovascular system, and hallucinations depending on the dose. We have seen lots of press on the people who were arrested in the death of Matthew Perry. They were giving him shots of ketamine, not troches, not capsules. Like with any medication, there is always someone who is going to misuse or abuse it. Think back to propofol and Michael Jackson. As with all medications, it should be prescribed by a knowledgeable physician and taken as directed. As with IV ketamine, you should not drive, make important decisions, or sign legal papers while ketamine is in your system. Medical marijuana. The legality of medical marijuana varies from state to state. So you need to look up your state's laws regarding marijuana. Marijuana has helped people with CRPS who also have anxiety disorders, and it helps them to come off benzodiazepines, which, as we mentioned previously, is a medication that is used to calm someone. Marijuana has also helped people with CRPS with sleep issues. It has helped with the pain of CRPS. I live in Florida where medical marijuana is legal and had a general, and right now, general use marijuana is up for vote. We will only discuss medical marijuana. Medical marijuana comes in different forms. Some forms are oral, some are not. But I want to cover medical marijuana all at once. Medical marijuana comes from the cannabis sativa plant, aka also known as medical cannabis. CBD from the hemp plant is legal under federal law and has less than 0.3% THC. THC is the cannabinoid that is found in cannabis. The term THC usually refers to the delta 9 TH isomer. It is the THC that causes people who are using marijuana for other than medical reasons to get high. Step one would be if your state allows medical marijuana to look up the regulations of your state or territory. Find a physician who is able to prescribe medical marijuana. Bring the paperwork required by your state or territory. Apply for your medical marijuana card, and your doctor may recommend a specific strain of medical marijuana and a specific route of administration. For example, inhaled, edibles, smoked. Medical marijuana strains differ, and they can produce different effects. Most people divide cannabis into three groups. Indica is believed to have a relaxing effect. Stevia is believed to have a more energizing effect, and hybrid, which is a mixture of the two. Which strain your physician will choose depends on the desired effect. We are not going to go any further into choosing a strain, as that is best recommended by your physician and your dispensary. Medical marijuana comes in different modes of administration. Vapor. The desktop vaporizer heats up the cannabis and expels the vapor into a balloon, which is inhaled. It can be smoked. It can be made into edibles. It can be an oral tincture, or it can be sublingual, which goes under the tongue. Side effects of medical marijuana include, but are not limited to, anxiety or paranoia, insomnia, drowsiness, increase in appetite, dry mouth and eyes, and a rapid heartbeat. Glucosteroids. Glucosteroids are anti-inflammatory medications. When you hear of NSAIDs, they are non-steroidal anti-inflammatories. Well, this is a steroid anti-inflammatory. Side effects include immunosuppression, bone loss, aggression, weight gain, and inability to sleep. Steroids can be an effective tool during a flare to decrease inflammation. Next, we're going to address opioids. Opioids, like any medication, you need to weigh the benefits against the side effects. Opioids for CRPS is controversial. We're going to stick to the facts without bias. There are very few randomized controlled trials of pharmacologic agents with those with CRPS. There are good data demonstrated that opioids can reduce pain and improve quality of life. Term opioids, narcotics are often used interchangeably. However, They are not the same thing. All opiates and opioids are narcotics, but not all narcotics are opiates or opioids. For example, the United Nations cannabis and cocaine are opioids and all are narcotics. In contrast, the Drug Enforcement Administration, DEA, maintains that only narcotics are substances that have been derived from opium, whether existing naturally or synthetically. Classically, the term opiate refers to the natural substances that come from the opium. In the US, prescription of opioids are regulated by the Controlled Substance Act. Not all opioids can be prescribed for pain. Non-prescribed opioids include things like heroin. Side effects of opioids are common and sometimes problematic. As with all medications used to treat CRPS pain, you should be prescribed the lowest dose that provides the desired effect. Side effects can include, but are not limited to, nausea and vomiting, constipation, cognitive impairment, somnolence, respiratory distress, and the possibility for some patients to become addicted. Opioids are a class of medication that are used to provide pain relief from moderate to severe acute or chronic pain. Acute pain is something like after a surgery that you expect to get better over time, whereas a chronic pain is something like CRPS where you continually have pain. We will look at the chronic pain when looking at opioids. Some common opioids prescribed include Dilaudid, OxyContin, Nucynta, Butrans, fentanyl, Stadol, Demerol, Roxicodone, and Ultram, but there are many, many more. A good one that is used is methadone. When you think of methadone, you probably think of something given to drug addicts, but it is actually an NMDA antagonist, so it works like ketamine does. Actions of the opioid. There are three classic opioid receptors. Morphine is how the other opioids are compared. So how many morphine equivalents is methadone, Dilaudid? If someone takes 100 milligrams of Nucynta 3 times a day, which is 300 milligrams a day, the morphine equivalent is 120 milligrams of morphine. That's something that your doctor will fill out or figure out for you, but it's nice to know where they come up with the dosages, and you may hear the term morphine equivalents. Opioid-induced hyperaglasia. If you think back to the What is CRPS show, we talked about hyperaglasia. We defined it as an increased sensitivity to pain. Things that are not painful for someone without CRPS could be very painful for someone with CRPS. Opioids can do that in addition to what your CRPS is doing and making the simple things more painful. As I've mentioned before, I was a patient of Dr. Robert J. Schwartzman and his partner. I mentioned in the intrathecal medicine pump show, I received morphine through this pump. Dr. Schwartzman had me wean off the morphine. He did not prescribe opiates to any of his CRPS patients. After years of getting ketamine, I became tolerant of ketamine, and my current doctor recommended Nucynta. Nucynta is a synthetic opioid. Nucynta is the only FDA-approved narcotic for nerve pain. Other classifications are antispasmodics or muscle relaxers. We briefly discussed baclofen when we talked about the intrathecal medication pumps, and we will address it again when we look at comorbidities of CRPS. Some people are able to take baclofen by mouth for their movement disorders, and others can't get enough into their system by mouth to help. I've taken some of these medications and will share my experience. Gabapentin, the side effects were worse than any benefit. Baclofen by mouth did not stop my dystonia. Lyrica left me sleeping all the time. Opiates, I now take Nucynta. Ketamine troches, I was able to come off my antidepressants altogether while I was getting IV infusions with home troches in between. And medical marijuana, I did not respond to at all. Ketamine troches capsules are compounded medications. Has to be done by a special compounding pharmacy. So is low-dose naltrexone and dextromethorphan. Low-dose naltrexone works on the CRPS by decreasing pain. A Stanford study tested LDN, and it was a randomized study, which means you had a 50-50 odd of getting the LDN, diagnosis at least 1 year before. CRPS pain was either in the arm or the leg. They'd been on a stable treatment for at least a month, not an opioid treatment or narcotic by mouth during the study. You can't mix LDN and opioids. And no one allergic to naltrexone. You could not be pregnant to partake in the study. The results were a decrease in overall pain and a boost to the immune system. LDN blocks certain proteins that affect the central nervous system. It works like an anti-inflammatory. It temporarily blocks receptors associated with triggers such as endorphins. Dextromethorphan is an NMDA antagonist, just like ketamine. So if you think back to the What is CRPS show, you'll remember that ketamine is an NMDA antagonist, and so is dextromethorphan. The side effects are blurred vision, confusion, drowsiness, slowed breathing. Both LDN and dextromethorphan have dosages that differ, and that dosage will be determined by your physician. Because it can cause sleepiness, it is most often given at bedtime. Hi, today we're talking with Mary, who's going to talk about some of the medications that she has been on for her CRPS. Mary, can you tell us by mouth what medications you were prescribed over the years?
A lot of them. I've tried, let's see, going back, I've tried every muscle relaxer that's been on the market.
Okay.
And the only one I can take is Sclaxin, which the generic is metaxalone.
Mm-hmm.
Because the other ones either didn't work or had side effects ranging from hallucinations to nausea, and like so bad that even with like a Zofran or anything, I would still have it. So it just wasn't, it's the only one I can take. And they're like, oh, why don't we switch up your muscle relaxer? And I'm like, well, unless there's a new one invented.
Right.
And then I was on gabapentin, and that one caused me I started having these, I didn't have migraines then, and I started
Right,
having such bad migraines with visual like blurriness, and that caused me such bad. They thought I went to the neurologist, of course, when you first start having migraines, they do like scans just to make sure. And I was in college at the time, so I went back to New Jersey where I live, and I got the scan on like a Friday. Went back to school in Long Island in on a Sunday, and they did a CTA and no, an MRA and an MRI. And then I
hmm
went back to school on Monday, and my mom calls around dinner time, and that wasn't unusual. I talked to her pretty much every day. Are you
right.
still having a headache? And I said, well, yeah. And she said, well, don't be alarmed, but your father's going to come pick you up, pack some things for a while. We're going to be going to Jefferson and Philadelphia.
Mm.
And then I got there eventually, and they did a CTA, and they said that what looked like, they thought I had brain aneurysms on the MRI, but what looked like brain aneurysms were just weird vascular I have that's normal, probably
Right,
been since birth. And then they figured out it was the gabapentin that caused it.
yeah.
And then the same thing with, I tried Lyrica. I can take Topamax. I am on that, but I have to stay at 50 because any higher I throw up, or when I was in college, I would forget to eat. Because I'd be
And
busy with college and I wouldn't feel hungry. So I would be like,
right.
well,
Topamax is actually not used for the CRPS part, but for the migraine part.
it was actually just for the
Many
nerve
years.
pain. They used it for
Okay,
the nerve pain first, but now on the migraines, they decided to keep me on it too.
right.
But because now I do have migraines, but and then I've tried multiple like opioids. It was just a lot of trial and error with that.
Mhm.
Currently on methadone and Dilaudid. Those have been the best combination.
Okay, well, that's the next area of classifications I'd like to talk to you about
Yeah.
because both are narcotics.
Yes.
So can you, without saying dosages, just tell us what your reaction to pain have been with those medications?
They really help because without any of them, and like I said, it took years to find the right combination of a breakthrough in a
Mhm.
not in a like at one like every day because otherwise like at one point I all I could do was lay in bed and scream and cry 24/7.
Right.
And now I mean I'm not cured, I don't work, but I can sometimes get out of the house, I can get rid around, and it's not that point except for maybe like a really bad flare.
Yeah, it's enabled you to at least be able to function.
Yeah, and have a quality of life.
That's wonderful.
And it really does help. And I was surprised when my pain doctor brought up the methadone because previously I had only heard of it for addiction.
Right.
And he said, well, usually for chronic pain, you take it more times a day and a
hmm
higher dose than for addiction. I said, well, I've had this doctor for multiple years. He's never steered me wrong. I trust him. So I said, I'll give it a try. And it
And
helped.
you take both together.
Yes. Yes. The lot of this for breakthrough, like, but I end
Okay.
up, and then the methadone is just like so many times a day, just every day, no matter what.
Okay. Well, thank you so much.